This meeting is being recorded.
Dr. Carolyn Owen, our presenter this evening, is the Associate Professor in the Division of Hematology and Hematological Malignancies at the University of Calgary. She completed internal medicine training in Ottawa and hematology training in Vancouver, followed by a research fellowship in molecular genetics at Barts and the London School of Medicine in London, the UK. Her prior research is focused on familial myelodysplasia and acute myeloid leukemia. Her current clinical interests are low-grade lymphoma and chronic lymphocytic leukemia, and she's the local principal investigator at the Tom Baker Cancer Center for several clinical trials in these areas. So we welcome Carolyn Owen tonight, and I'll just turn it right over to her.
Thank you, Betty. So welcome everyone. I know that you do these group meetings quite often, and I don't know your whole agenda to know what you've spoken about previously, but initially the discussion for having this presentation did relate around a clinical trial for relapsed Waldenstrom's. The trial isn't specific to relapsed Waldenstrom's, but it's one of the subgroups within the study. And in order to have people know about the study and understand where it might fit into treatments, we have to obviously understand who might ever be eligible. And so we thought it would be reasonable to have a bit of a conversation around the approach to relapsed refractory treatment in general, which is where the sort of idea about discussing therapies after bendamustine, because bendamustine and rituximab really is the standard therapy for Waldenstrom's across Canada. So for those who've received a therapy, most people will have had that as their first treatment. So just kind of setting the scene, some of you may have never had treatment because obviously having this diagnosis of Waldenstrom's or the World Health Organization pathology classification, the diagnosis is supposed to be called lymphoplasmacytic lymphoma. So this is a low-grade lymphoma or a slow-growing non-Hodgkin lymphoma that looks, the cells look a little bit like plasma cells. So plasma cells are the malignant cells in myeloma. And so sometimes there's some crossover in treatments and in sort of diagnosis between this Waldenstrom's and myeloma, but Waldenstrom's is actually a lymphoma. And so like all of the slow growing non-Hodgkin lymphomas, we still have a treatment plan that only recommends for therapy for people who have symptomatic disease. And that means that you can actually have the diagnosis, you can have a bone marrow that confirms you have this lymphoma or a lymph node biopsy, but that in and of itself doesn't typically motivate treatment. And the only reasons to have treatment are if the disease is causing some kind of problem. And for lymphoma, obviously, that's a lymph node cancer. So many patients with slow-growing lymphomas will have big lymph nodes or big spleen that are bothersome. But actually with Waldenstrom's, it is more common that you don't have a lot of big lymph nodes. So often it's only the spleen that's enlarged. And usually the spleen enlargement itself isn't actually the biggest problem. The problem is typically bone marrow involvement that makes you not able to make all of your normal blood cells properly, causing usually anemia and fatigue, or the so-called B symptoms of fevers, drenching night sweats, weight loss. Those can also happen when the disease is very active, more commonly also in the relapsed setting than the frontline setting. And then unique to Waldenstrom's is the making of this IgM protein from the lymphoma. And this is a very large antibody, the largest of the different kinds of antibodies. So it remains within the circulation. It doesn't sort of get into the tissues because it's too big to get out. And so because it remains in the circulation, it can kind of gum up the circulatory system, cause thickening, the so-called hyperviscosity, and that can be associated with its own symptoms of bleeding, mental status changes like
So
concentration
whenever you want to sell them, you
problems,
can have this here.
or kidney or other dysfunction. So I mentioned that BR is the most common treatment in Canada, this Bendamustine Rituximab, and the justification for that came from this larger study of lots of different low-grade lymphomas. So Waldenstrom's was only one subgroup. And you can see these curves are really common to hematology presentations, to any kind of cancer presentation. I'm sure you've seen them a million times before, but I'll just explain really briefly the principle of the Kaplan-Meier curve is that the curve starts at 100%. So at the beginning of the study, 100% of people are in the study. And then every time people have an event, they fall off the curve and the curve begins to descend. And the events for progression-free survival are either progression of lymphoma or a death. And so if after, let's say 24 months here at the 2-year mark, if everybody was without relapse, without death, they were all still fine, then the curve would still be straight at the top at the 100%. So instead it slowly drifts down over time. And you can see that in the comparison between the Bendamustine Rituximab, which is the red curve, and the R-CHOP, which was sort of similar to our CBP that we gave in Canada more than 10 years ago, that there's far less people having these progression events or deaths, that they're remaining well for longer with this BR. And when you look on the right, that's the data specific to Waldenstrom's, and you can see that it's a really small number of people. So it's 22 patients in one group and 19 in another. Like, you'd never be able to report that as its own study. So while it was significantly better with BR, there's a real margin of error that could be included in here, because you could have just a few patients that happen to be extra good or extra bad that really kind of pull your curves down when you have so few people. But the other thing that was good about the BR was that you didn't lose your hair. There's actually less infections and admissions. So in general, people tolerated the treatment better. So that's our standard first treatment. If you've had treatment in Canada for Waldenstrom's, this is likely what you have received. And most people will have really lengthy remissions, potentially for more than 6-8 years. Then the question after that comes, to provide maintenance rituximab or not after the Bendamustine and Rituximab. And this is a really interesting sort of contentious point now in the US, when this follow-up study from the same group actually that had proven that BR was better, this German group, when they published this study result declaring no benefit of rituximab maintenance for Waldenstrom's, then rituximab maintenance was pretty much aborted in the US. And so they don't do this in the US. And so those people who travel down south or maybe gone to a patient education in Arizona, I know some patients of mine have done that for CLL, that you might have heard that this is an unpopular undertaking. So the study was specific for Waldenstrom's or for BR patients. And they looked at giving our maintenance versus not after finishing the BR. And at the end of the day, they found no statistically significant difference between the two arms. The problem with the study is that they did not have enough patients to be able to confidently assess for a difference. So the patients who got the maintenance had 8.5 years of on average before recurrence of disease, and the patients who did not had 7 years. And so, 18 months isn't a massive long time, but at the same time, it is a difference. It's just that in the study, it wasn't statistically significant. So we still offer people maintenance rituximab in general frontline to try to let them have the longest possible remission. But personally, I stopped doing that during COVID, because we know that the rituximab stops responses to vaccination, and that effect lasts up to a year. So if you take the maintenance, then you can't respond to vaccines for up to a year after you finish your maintenance. And so if the next COVID variant was to be more dangerous, if you're already embarked upon rituximab maintenance, even if you quit it, you still have to wait another year before you'd be expecting to respond to vaccines. So that risk didn't seem worth it to me since the pandemic started. But when COVID is no longer a massive big problem, then I think this will be a discussion for patients again. And it is still funded, at least in Alberta, and I think in most provinces across Canada. So it's an option to extend a remission, but it isn't likely to make people live any longer overall, because they didn't even show an overall survival advantage, even in other kinds of low-grade lymphoma where the difference in remission duration is even longer. So what after that? So this is most people who receive Bendamustine and Rituximab. As I said, many people will be diagnosed, they won't need anything. Then when they need treatment, they can have this very effective chemoimmunotherapy, and then they can hopefully have a really long remission. We're looking at 6-7 years on average. And so the next most common treatment for Waldenstrom's at relapse in Canada is ibrutinib. And I say ibrutinib and not just a BTK inhibitor, because ibrutinib is the first in class of the BTK inhibitors. And it has quite a generous compassionate access program. And so many patients have been able to get access to this drug through the program. And I know that the newer BTK inhibitors have good data in Waldenstrom's as well, but they don't necessarily have funding or availability as well. The one that does is zanubrutinib. We'll talk about it next. But there's another one also called acalabrutinib, and it isn't really so easily accessible for Waldenstrom's. But because ibrutinib was the first one to come on the market, it has the longest history, and you can see that that patients can have a really long remission at relapse when they get ibrutinib. There's some added data here, talking about things like whether you have a MYD88 mutation or not. And there's some suggestion, obviously, that the higher risk patients who don't have that don't do as well. But that doesn't matter in terms of ibrutinib. Everybody gets at least some kind of benefit from the drug. So it's the standard sort of second line therapy nowadays. There was a long follow-up study just of 30 patients who'd never had treatment before, and they also have an excellent outcome. And there's a lot of studies nowadays. I think your group talked to Dr. Berenstein about his frontline study, the BROM study that is BR with some acalabrutinib. So I mentioned that's the same family as ibrutinib. There's other studies going on right now of looking at ibrutinib alone, frontline, or ibrutinib with rituximab was the study. That's not funded in Canada because it isn't compared against a standard comparator. And so I'm not really sure whether we'll see BTK inhibitors frontline anytime soon in Canada, except on clinical trials. And so this is what I mentioned, the acalabrutinib. And then the zanubrutinib data is actually a really good study because it's the first head-to-head between two BTK inhibitors. And it was specific to Waldenstrom's patients. And it was the ibrutinib, which is the first of the BTK inhibitors, compared against zanubrutinib, which was one of the newer ones. And you can see the curves on the right that they're very overlapping. And so clearly all of the BTK inhibitors in this class, these covalent ones, we expect to work really well. And the advantage to the newer ones, the zanubrutinib and the acalabrutinib, is they seem to have less side effects. So I would favor today, if I had a patient in my clinic with Waldenstrom's who was relapsed, who needed a new therapy, I would favor zanubrutinib now, sort of based on this study. And it also has a very generous compassionate access program that does provide access to that therapy quite easily. So after a BTK inhibitor following BR, what else is there? So there's always chemo. Any kind of chemo for any kind of lymphoma in relapse often doesn't have sort of specific funding restrictions. So I know some provinces have harder time getting rituximab a second time. And so some provinces, it might be harder to get retreatment with a chemotherapy with rituximab. But if there was no sort of good therapy available, any kind of lymphoma regimen might be suggested. There's some data for, as I mentioned, myeloma being sort of linked to this kind of lymphoma. So drugs used in myeloma, and those would be things like bortezomib or Velcade. There's stem cell transplant using your own blood stem cells, which is sort of fallen out of favor for Waldenstrom's because it doesn't seem like it's curative, even if it gives a long remission. Now that there's newer agents, they tend to be favored, but that's still a possibility, and some people may have been treated in that way several years ago. But on the right here, you'll see this is not an exhaustive list, it's just the most recently done list that we found. And so there could be new ones added on, but it just shows you how many different things are being studied and studied in combinations. So daratumumab is an antibody drug against CD38, which is the plasma cell marker. And this is a drug that has sort of made a massive difference for myeloma again. So it's another myeloma drug being investigated for Waldenstrom's with or without ibrutinib. Then venetoclax is another anti-lymphoma therapy that works super well for CLL. And so it's extrapolating data from another sort of non-Hodgkin lymphoma back to Waldenstrom's. So you'll see there's lots of different studies. The reason I've highlighted this one is because this ARQ351 is a new kind of BTK inhibitor, and it acts differently from the ibrutinib family. And it's the drug that is available in a clinical trial in Canada today in both Montreal and in Calgary. This is just showing you kind of a bit of an idea of how long it takes for how long it's taken for our knowledge in terms of this BTK inhibitor class. So the BTK inhibitor, the BTK enzyme was first discovered in young men with X-linked antibody deficiency as the reason that they couldn't make antibodies. Their B cells didn't work because they were missing this enzyme. And then they realized that they could try to stop that enzyme in some B cell lymphomas. And then they put it into trials, and it literally was funded and approved within a few years, which is some of the fastest we've seen for many drugs because it's such a good targeted therapy. So this is the importance of BTK inhibitors in Waldenstrom's. And ibrutinib was the first one to come in, and it's a irreversible binding to one site on the BTK enzyme. And the second generation newer ones that I mentioned, the acalabrutinib and zanubrutinib, are the only two that are kind of available in Canada. They act on the exact same location as ibrutinib. They really are just like ibrutinib 2.0, but with less side effects. So they're more specific to the BTK. They have less off-target effects, but they do the same job. So if for some reason ibrutinib did not work, or you were resistant to ibrutinib, there really isn't any reason to think that acalabrutinib or zanubrutinib would be helpful in that situation. However, the third generation BTK inhibitors, pirtobrutinib, which was previously called LOXO305, or Nemtabrutinib, which was previously called ARQ351 and is now called MK1026, these are reversible, non-covalent. So they act on a different part of the enzyme and in a different way. So if you are resistant to ibrutinib, usually that comes through point mutations that have changed where the drug binds on the enzyme. And so because this third generation class of drug acts on a different part of the enzyme, it doesn't matter if you're resistant to ibrutinib. So in theory, these agents, the third generation, should work in people who have progressed on ibrutinib or zanubrutinib, which are the drugs that are commonly used in Canada today. That has been proven in CLL, which is a related lymphoma, as I mentioned, which is sort of a bit further ahead because ibrutinib was first funded and available for CLL and works very well in that disease. So we know that as a proof of principle that in CLL, that if you fail ibrutinib because you progress on it, your disease becomes resistant to it, that you can respond to this class of drugs and have a nice long remission. The number of patients treated with Waldenstrom's where we can say that and prove that is far fewer because it's a less common disease, but in theory, it should work. And so this is just showing you a bit of what I was talking about, that ibrutinib targets the BTK inhibitor, but the red circles are all the different enzymes in this sort of kinome plot of all sorts of tons of different enzymes. And acalabrutinib and zanubrutinib were made with a goal of having less impact on other non-BTK inhibitor enzymes. And so the number one side effects, number 1 and 2 side effects with ibrutinib that were bothersome and caused people to not be able to take the drug and that led us to want a better drug are atrial fibrillation, which is an irregular heartbeat, and then bleeding. Hypertension, so high blood pressure, also a problem with ibrutinib. And these are all better with the 2nd generation agents, like with zanubrutinib, except maybe the hypertension isn't such a big difference. So as I mentioned, the ibrutinib, you get resistant to it by developing a mutation, usually at its active binding site or the one enzyme downstream. And so and then it grows out from there. And so we expect that would not be that would not be impacted by the new generation non-covalent BTK inhibitors because they act in a different way. There's other possibilities of ways that you could affect this pathway. So the non-covalent or reversible BTK inhibitor that is available in Calgary for a clinical trial is one way, but there's new clinical trials of BTK degraders. So it's sort of like another way of getting rid of the enzyme that again is totally different from the way that we do it right now with ibrutinib. There's CAR T cells, which is immune therapy where your own T cells are removed from the body and altered in a way to make them more likely to kill off the rest of your own lymphoma cells. And then there's, as I mentioned from the clinical trial list, a whole bunch of sort of combination studies using often myeloma type drugs or other lymphoma type drugs or drugs in combination with ibrutinib. So these are lots of different sort of hopeful approaches for the future. But today, searching on clinicaltrials.gov to give you an idea of where you can go in Canada to get different drugs, there's not a ton of them. LOXO 305 or pirtobrutinib is the reversible BTK inhibitor that has the most data because it is the first one to come out. And so it's the one that we sort of get our data from. We're expecting the Nemtabrutinib or the clinical trial drug that I have to be similar to this one because it acts on the similar pathway, but we don't know, we can only sort of assume that they will be the same, and with time we'll see. And so this is the pirtobrutinib data in patients who have had previous BTK inhibitors. And the reason that the colors fall below the dotted line if the amount of disease in the patient is less, and they go above the line if the amount of disease in the patient is more. And so you'll see that CLL, as I mentioned, is a really common lymphoma, and that's been really well studied. Mantle cell lymphoma is also, not super common, but really uses a lot of the BTK inhibitor class, and it works in most people, but some it doesn't. And then the Waldenstrom's data, again, as per usual with Waldenstrom's, there's not a lot of patients, but you can see that the majority of them have this really good drop in amount of disease. If they've, the gray bars are people who were never given ibrutinib or that family before. The light blue bars are the ones who've had ibrutinib or that family before and stopped it for side effects. And then the dark blue bars are the people who've had ibrutinib or that class and progressed while on it. So each individual group is not a lot of patients. And the 2 patients who did not respond to this pirtobrutinib who had progression or increase in extent of disease, they were people who had progressed on ibrutinib before. So that is sort of the highest risk group. So you met, as I mentioned, I know you had a talk from Dr. Berenstein previously about this BROM study, which is Bendamustine Rituximab, so our standard therapy in combination with acalabrutinib for previously untreated Waldenstrom's. The good thing about that study is it's a phase 2 study, so there's no randomization. If you're eligible for the study, you sign on to the study, then you will get that therapy. There's no kind of allocation to something different. And then the Nemtabrutinib or MK1026 study that I have at our center is again a phase 2 study. If you're eligible for the study, then you will get the drug, and it is intended to be a study for people who have relapsed disease after ibrutinib, zanubrutinib, acalabrutinib, one of the currently available BTK inhibitors. So going for our sort of highest risk population of Waldenstrom's patients in Canada. The study is open in Calgary and at the Jewish General in Montreal, with Dr. Assouline running that study in Montreal. And so I've given you the information there if you live closer to Montreal and you are looking to travel there. You have to have a confirmed diagnosis of Waldenstrom's, which would mean that you can't just have had a high IgM and been treated. You would have need to have had a bone marrow or a lymph node biopsy, some sort of pathology. And then you have to have had standard prior therapy, which includes chemoimmunotherapy, and that is an antibody with chemo. So it's BR in Canada for most people, but R-CHOP, R-CBP, it doesn't really matter. And then when we say a covalent irreversible BTK inhibitor, that is either ibrutinib or zanubrutinib in Canada, or acalabrutinib, I guess, if you got onto the BROM study and then you progressed after. The thing that's difficult about this study is that they want, like always with Waldenstrom's, for there to be a reason that you need to be treated. And so you can't just have the disease, it has to be kind of symptomatic. It's quite easy to achieve a goal of, a requirement for being called symptomatic if you just say that you're really tired, because fatigue is a subjective thing. But then they also want measurable disease. So I've highlighted this because it is something that it is not, I would say, in a part of your standard day-to-day practice, something that you would already have proof of. So you would need to either have a CT scan that shows a measurably enlarged lymph node that has progressed from previous. And as I mentioned, with Waldenstrom's, lots of patients don't have big lymph nodes at all. It's more bone marrow-based disease. You need to have an IgM, if you're just doing an IgM, of more than 45 by Canadian lab testing. And most people don't want to let their IgM get up to 45 before they do anything, but so it's a pretty high number. If you had control of your monoclonal protein before and now it's progressing, you wouldn't have wanted to wait till above 45 to get on the study, but that is the requirement. Or your bone marrow has to report that you have more than 70% of the bone marrow involved by the lymphoma, which means that most people are going to need to have a bone marrow to get onto the study. You're also supposed to have a bone marrow for the sake of the study to do extra sort of science tests. In general, when you do bone marrows on patients with lymphoplasmacytic lymphoma or Waldenstrom's, there are a lot of lymphoma cells in the bone marrow, even if the blood counts look pretty good. And most pathologists are kind of influenceable. So this guesstimate of how much of the bone marrow is replaced by lymphoma is a bit subjective. So if I had a pathologist who said, oh, 50 to 60% of the bone marrow looks like it's lymphoma, and I went back to him and I said, oh, please, it has to be more than 70% to get into the clinical trial, and this patient has no other treatment options, they would alter their report and say, oh, on retrospect, I've looked more carefully, because it doesn't make a difference. It's either involved or not. And they are just sort of eyeballing that. So I think that if you really wanted to get into the study and you thought you were eligible, you probably will meet eligibility criteria, but you would need to do a bone marrow to get in. And I'm going to go slightly off topic here, but quite quickly, because everybody has heard a million things about COVID and about vaccines and COVID, but this is a very topical issue. We know that patients who are on BTK inhibitors and patients who've had rituximab within the last year have very poor responses to the vaccine. So if you've done exactly what's been asked of you and gone and had 3 or 4 doses of vaccine, you may still have 0 protective antibodies against the COVID-19 virus, or you may have some but suboptimal level of vaccine protection. And again, this has been most carefully investigated in CLL because there's lots of those patients, but there's no reason it wouldn't be the same in Waldenstrom's. And so with the first 2 doses, we know many patients didn't get any response, but actually there was some level of response in getting the 3rd dose. It was only 15% of people who didn't respond before who now respond, but that kind of does mean that every added dose is useful for people with immune suppression, because you may actually eventually receive protection. But here's the new data is that there's a new long-acting monoclonal antibody called Tixagevimab, CILGA, I can't remember, I can't see it from my own Zoom things here. The trade name is Evusheld, so you probably have heard of it that way. As an academic physician, I'm not supposed to call any drugs by their trade names, so I'm going to call it TIXA-CILGA because that's what I tend to refer to it in my notes. So this is an antibody that was developed to pretty much mimic antibodies that were found in people who recovered from the original COVID wave of infection. So this is sort of based off of protective antibodies against the spike protein from the original COVID. So remember that Omicron is now, variant who knows how many. So there's possibly some not as good potency for this antibody as the clinical trial data suggests. But it's the first study to look at a primary prevention study. So trying to stop people from catching COVID, not just stopping them from getting severe illness once they've got COVID. So currently in Alberta and the rest of the country, to my knowledge, if you got a PCR positive test for COVID as an immune suppressed patient, which means you've been on active therapy since December 2020, or you're on a B-cell inhibitor, or they don't tend to include hypogammaglobulinemia, but they should, because with Waldenstrom's, most people's immune systems aren't working well, then you can get access to Paxlovid, which is the, and again, I can't remember the proper generic name for that, is the antiviral pill that prevents viral replication. So it tries to prevent the virus from expanding and making your body sick. You used to be able to have a choice of getting the Paxlovid or this Cilgavimab, which was an antibody to help prevent severe infection, but actually Cilgavimab doesn't work well against Omicron, so they removed that from treatment choices. But up until today, up until this week, the only therapy for COVID was treatments when you were hospitalized to prevent death. So, worsened severe infection, because it's called severe just because you had to get admitted, or to prevent severe infection in people with confirmed PCR positive tests. So this would be the first access to a true preventative therapy. And in Alberta, we will have the access on Thursday. So this is very sort of hot off the press. And I'm sure it's being rolled out at a similar speed across the country. The study was, as I said, primary prevention. And so it was done before vaccines were available. And so they targeted the population of patients who were expected to have a high chance of dying of COVID. So old people, people in nursing home, people with diabetes, heart disease, chronic obstructive pulmonary disease. Very few of the patients actually were immune suppressed, so only 4%. They were obviously motivated people who didn't want to catch COVID, who knew that they had any of these chronic problems. So here's the big hitter data. This is the reverse to what I showed you in the curve before, where you start at 100% of people alive and well, and you watch them, and if the curve stays at 100%, that means nobody's dying or having relapse. This is looking for infection, so the curve starts at 0, and every time somebody has a confirmed infection, the line goes up. And so the placebo line is on top because there's more infections in the placebo group than in the TIXA CILGA group, and it was a very notable reduction in infections. Take note, however, that when the first wave of COVID happened, or the first couple waves, when the study was being run, even though everybody was very afraid of COVID, the infection rates within the community were really low, right? There was never even 1% of our entire population infected at one time. So at the end of this study, 1% of patients in the placebo arm had caught COVID and 0.2% in the TIXA CILGA group. So it was very protective, but how will that pan out today when with Omicron, there's estimated rates of sometimes up to 20% in certain communities of active COVID moving around? So is it still going to be that big a difference? Is it going to be that protective against Omicron? We don't really know, but there's no reason to think it shouldn't provide some protection, which is very appealing for people who don't have protection already. There's one warning from the study, which was that there was a higher rate of cardiac events in the antibody arm, and it was 0.7% of events in the treatment arm and 0.3% in the placebo arm, so double the number. Remember, these patients were high risk for heart problems because many of them had them already, because that was why they were selected as being at high risk of COVID deaths. It doesn't make a lot of sense for an antibody to cause heart problems. I don't really understand the mechanism, but it is something to consider that if you have an unstable heart problem, you've had a heart attack in the last 6 months, you've had heart failure, any issues like that, then it's recommended that this is probably not a good treatment for you. So the only people who really are recommended not to be receiving this are those people. The other problems are injection site reactions. It's painful because it's an IM injection into your backside. And I think they give 2 doses. I can't remember how far apart. So this I thought was important information for you because it's going to be a lot of work in the next while, because unlike the other COVID treatments where you had to have confirmed COVID, this is something that people can be offered to try to stop them from getting COVID. So it's something that can be offered to anybody who's out and about in the community who meets the criteria. And in my population treating lymphoma, that's like most of my patients. And there is no process by this. I don't know if on Thursday I'm supposed to start calling my hundreds of patients and saying, do you want to receive this? Do you not? I'm going to fill out the form for you. So if you think that you're eligible, then you probably want to be proactive and contact your own physician, because in Alberta, at least, it's the specialists who are supposed to order this, which is different from all other COVID therapies. And the criteria that have been agreed upon in Alberta are probably the same as the criteria, or very similar in other provinces. And it's no active COVID infection within the last couple of weeks. And if you have had active COVID, you have to be completely resolved from your symptoms. You have either on with receiving rituximab within the last 12 months, an auto transplant or any allo transplant within 12 months, or being on a B cell receptor inhibitor. And so that is anybody on ibrutinib, zanubrutinib, one of those classes of drugs would be eligible for this preventative therapy. And that was it. And I see in the chat, there's a group. Okay, so somebody said, how can we get Evusheld? And so I've just sort of explained, in Alberta, you would call the cancer center and say, can somebody please ask Dr. Owen to order me some Evusheld? Because obviously that's how it's gonna, I think in other provinces, it's gonna be the same. It says, is it available across Canada? There's no cost, because like other funded COVID therapies, if you're eligible and your doctor orders it, you will get it without cost. In Alberta, it's being provided at a private infusion clinic. So I will order it, and the infusion clinic will call the patient, and they will go to sort of not to the hospital, but to this sort of other infusion center to receive it. I was told by my doctor today that I'm on the list, but it will be a while. So I don't know that it'll be that long, because they have a limited supply of drug. So even if a whole bunch of doctors order it right away, either you're going to get it or you're not. Yeah, they've ordered lots and lots of doses, but it is actually relatively restricted. Oh, it's 1 dose. Somebody said they got it in Florida. Thank you. So, but the study lasted, they did the original report at 3 months, but they did a follow-up at 6 months, and the curves were still separating from the 1 dose. So the other good thing is that it continues to protect for quite a while. So getting it at the beginning of the summer when the rates of infection are not so high is maybe not, like, if you have to wait, I actually think maybe you don't need to feel terrible about that. Just spend a lot of time outdoors and don't socialize indoors until you've had it, because you want it to still be acting when autumn comes, and there might be sort of a resurgence of infections when people move back indoors.
I got a couple of questions sent to me. If I may ask you, Dr. Owen?
Yes, please do.
One asked if there's any comparison data between the Bircho and the Nepta with respect to side effects and efficacy. How are they the same and how are they different?
So you don't have a choice, right? So Nemtabrutinib is only available in a clinical trial, only available for patients who have failed ibrutinib. So it isn't actually sort of a kind of fair question, but this new class of drugs, so we're kind of basing our data more on the pirtobrutinib, which is sort of the sister to Nemtabrutinib, and is a bit more advanced, and more patients have been treated. So far, there's no cardiac signal of AFib. There's no, and there's a very low bleeding rate reported. So the 2 biggest problems with ibrutinib don't appear to be big problems with this class. So I think it's going to be either better or certainly no worse. Standard side effects of, getting nausea or diarrhea at the beginning because it's a pill, you can get a rash from any drug, but actually the side effect profile looked pretty good.
Okay, and chemically it's completely different or very close?
Yes, yeah. So we talk about covalent and non-covalent is bonds, like chemistry bonds. So the ibrutinib, zanubrutinib, acalabrutinib drugs have covalent bonding to a single enzyme site, in a sense like the drug latches on to the BTK enzyme and stays there and stops it from working. Whereas the newer class are reversible. They make a non-covalent bond. It's almost more like a sort of, I encircle the enzyme and then I let it go and then I come back to it. In theory, that might actually be a better mechanism that would be less likely to lead to resistance. But then again, it might be less durable because there might be other escape mechanisms. So there is a head-to-head of pirtobrutinib versus ibrutinib in CLL, I think, that is predicted to begin, but you're not going to know those data for a long time.
Okay. And back to your clinical trial, a couple of people have asked the same question. Right now, the sites are Calgary and Montreal. Is there one coming up, a site in Ottawa maybe, or Toronto? Do you know anything about that?
I don't. The only way I know is because we had the early phase study where it was phase 1, where you have to give back, participate in every patient individual data every week kind of discussion. I know that Dr. Asseling's site was open when ours was. And when I last checked, they were the only 2 Canadian sites, but I don't know whether there's others pending. It's sort of, that's kind of beyond my kind of level of ownership within the study. It is an industry sponsored study, which means that if you lived in Ottawa and you traveled to Montreal, they would reimburse your travel. So it isn't nice. It's a lot of visits back and forth for something, but if you were really in need of a study, says today clinical trial shows Ottawa as a site. Look at that. Somebody's more up to Googling while we're talking. So then there you go. Maybe that's true. So somebody said, been on pirtobrutinib for 18 months and all blood counts normal, no side effects. So that is, that is the hope. This newer class does look highly effective in the related diseases, and it has sort of very good side effect profile. So somebody said they want to start zanubrutinib frontline. I'll be honest, I'm not convinced that that's good for our healthcare system in general, because the BTK inhibitor class are indefinite and progression, continuous treatment until progression, and we can't really afford that. They're so the BR data, the BR is so effective for people to have 6 months of treatment and had nothing for many years before they get a BTK inhibitor, that most provinces aren't going to fund that. So the zanubrutinib compassionate access program is very generous. And I don't think you're going to get cut off if you start, but I don't think it's going to get funded by the province. It's a judgment, right? Between there's no head-to-head between a chemoimmunotherapy and a BTK inhibitor to see which sort of leads to longer overall survival. And there's very little data to go back to chemo after you've already failed a BTK inhibitor. And so yeah, I'm not gonna weigh in to disagree, but it isn't the standard Canadian approach. Steve Freeland said a week ago that all patients should have genomic studies done to get the most effective BTK inhibitor. What do you think? There's very, very limited data for mutations being present before you're exposed to it. And there's not a lot of data to say that different genomic variants are, the subgroup analyses from zanubrutinib suggesting that the MYD88 wild type patients did just as well as the ones who were MYD88 mutated, but then in the ibrutinib data, they didn't. These are small groups. It could have been chance. That's not a head-to-head study. I think that's really bad science to put a lot of strength on that. And I don't think it's available routinely to have that done in Canada. Somebody asked how many visits are required for clinical trials. Always a lot. And we've just moved to phase 2. So it's day 1, 2, because they do some PK levels, like some drug levels in the blood, and then 4 weeks later, and then 4 weeks later for about I think almost a year or 6 or 8 months. And then it goes to every 2 or 3 months. It'll always be lots of visits on a clinical trial. What options if no MYD88 mutation? Yeah, so there's some suggestion that that's a slightly different disease, but it's a rarer entity out of a rare entity. So you're looking at subgroup analyses from clinical trials where there's very few patients, and you can imagine that, you know, we could put 4 of us together in the room and one person could have really bad disease, and if we're say, oh well, we're going to use us as the example for, you know, Canadian Waldenstrom's patients, and we're all going to look terrible because one person just happens to have very resistant disease. So when you do that in a clinical trial and you start looking at subgroups that aren't planned or powered, it's a really statistically unsound. And so I think that if there's a lymphoplasmacytic lymphoma morphology, meaning that's what it looks like under the microscope, and there's an IgM protein, that having the same therapy as other patients who have the MYD88 mutation is very reasonable. And if the therapy doesn't work, then you would be able, you know, you'd be altering therapy. But the clinical trial doesn't differentiate for the presence or absence of the MYD88 mutation because it, you know, we don't have good data to tell us that we should alter our therapy for that. I'm an autotransplant patient from 6.5 years ago, no treatment. Yes. Does that mean I'm not eligible for Evusheld? Yes, actually it does. I argued that we should have hypogammaglobulinemia, secondary hypogammaglobulinemia included, and I think they did write it into the Alberta requirements. So if you know that your IgG level without gamma globulin replacement is really low, then you probably haven't made a good IgG response to the COVID-19 vaccine. But if you're otherwise well, you are in remission and more than a year from therapy, then you are not eligible for Evusheld because there is a limited supply and you probably don't need it, right? Most people who are catching COVID, who are in remission more than a year from therapy, are not getting severe disease today when they're vaccinated. So those people aren't those who are being targeted for the antibody. If you start your treatment with BTK, or if no, what to take if you fail or is this too early? Yeah, so that's the whole point, is that there's really no data for going from failing a BTK inhibitor back to chemo. There's not a lot of biological reason to think it wouldn't work, except that you've now selected for a more sort of resistant clone. And in general, when you fail on a chronic progressive therapy like a BTK inhibitor that's supposed to be continued indefinitely, especially if there was maybe access to second generation BTK inhibitors eventually, and then you know, most people don't feel comfortable giving a time limited treatment and then stopping and giving you nothing. The advantage of the time limited therapy first time is that it's probably the only time in your life that you'll ever have. Like Stu is saying, he's had 6.5 years with no treatment at all. You get to feel like you're a healthy, normal person and you're not taking a drug every day. If you start with a chronic suppressive therapy forever, it's hard to envision that you'll ever in your lifetime have a time limited therapy, stop drugs and be on nothing forever, right? So that's part of why I think people like the idea of being able to have a, you know, an effective treatment that stops, and then they can have a long remission, and then they can go to these more targeted sort of indefinite treatments later. But the counter argument from, you know, if you were the Zanubrutinib makers would be, well, if the Zanubrutinib works really, really well, then you have a relapse and then maybe you'll live just as long, but you won't have had a time off drug. Their theory would be that you would live even longer. If we knew that was true, then we would change our treatment, but there's no data to suggest that.
Would you give Bendamustine Rituxan as a second time to a person who was very successful with the first round if they relapsed?
Oh, so that's a really good question. And so the problem with bendamustine is it is an alkylator and pure, so it can, you do have this worry about causing, you know, second cancers the more times you get exposed to chemo. And people with Waldenstrom's tend to be a bit older. And so if you've had a nice remission, time off therapy, now you're going to be older than you were the last time, then maybe the non-chemo options are better because your DNA has already been sort of impacted once by BR. So there isn't a study to say that you will live longer overall if you had like a 10-year remission from BR first time to get a BTK inhibitor second line instead of getting chemo again. But every time you get chemo, you usually have a less long remission and you're exposing the bone marrow to that risk. So it's an option, but I think most people would favor the BTK inhibitors second line, even if they had a really long remission first line to chemo. But it would be a thought. Like Stu's given us had an auto transplant. I bet that wasn't his first treatment. So we were doing, you know, even more intensive second chemotherapies and giving people really long remissions. And so he'll get a BTK inhibitor third line and probably be very happy that's how it went if you have all these years off drug. So it is something to sort of consider in individual cases.
Doctor, I'm not sure if you answered it. Someone asked if you've had COVID, would you recommend the Evershield?
Yeah, so I actually thought they shouldn't. I know that sounds terrible without any science, but there's a limited supply, right? And if you had COVID and you didn't die and you didn't get really sick and you recovered, then you'd actually think that those people should be sort of less afraid. If you got COVID, you went to hospital, you were really ill, and now you finally recovered, then I think, yes, you should be eligible for it because you've proven that you're susceptible to severe infection and that this could make you really poorly. But I mean, a lot of people have caught Omicron and, laughed it off almost. They had a positive test, they got a little bit of Paxlovid, and then they were fine 4 days later. Do those people need Evusheld if they meet the criteria? I don't think they need it as much as the people who are, really afraid, locked themselves in their home and haven't gone anywhere in 3 years and are depressed because they have no social interactions because they're so afraid of the virus, and they're older and they've never had infection. So yes, you're eligible if you've had active COVID and you've recovered. I think you should think about whether you want it, but that is not a restriction. Any data about possibly added protection from COVID using sub-Q or IVIG for hypogammaglobulinemic patients? No. And I think it's because you can imagine that even now, where the rates of Omicron were super high recently, our pool of product of IVIG or sub-Q IG is still, you have to clean it, and it's still going to be from the general population. There's not very much protection in that. So you could be protected against pneumonia, community-acquired pneumonia, or secondary bacterial pneumonia that may make you even sicker after catching COVID. But I think that statistically, it's very unlikely that sub-Q IG or IVIG are actually protecting you against catching COVID.
Any other questions for Dr. Owen, who's doing a fabulous job answering all our questions? We do have a lot. I think that's
okay. My husband just texted me to say that he can pick up my daughter at daycare when we're doing this 6 o'clock pickup, so it's all fine.
Sorry, someone just added one more, Dr. Owen, if you'd like
As
to.
a treatment-naive patient, but with a very low IgG, does it mean my 4 vaccines work? So this is a great question. We had this vaccine immune protection study that we were doing across Canada. It was led from somebody she was an Ottawa based, and we don't have all the data sort of interpreted yet, but I mean, it's an immunoglobulin based serology test. If you have no IgG or really low IgG, you're never going to have a robust Ig response to the COVID vaccine. The problem is that the vaccine can work in more than one way. So it can also improve T cell response to the virus. We were always taught in medical school that the majority of the response of the body to a virus, the protective response is through the T cell system. The problem is the T cells, you can't check your T cell response except in very complicated lab-based studies. So my argument for somebody who has hypogammaglobulinemia is that you should have got vaccinated, and the vaccine may have provided good protection because it may have given you a good T cell protective trigger, but I bet you don't have the protective antibody levels if we were doing levels. Like, they have level testing. There's private labs that are doing it, and then they do it in the US. The reason it's not being done in Canada is because there hasn't been a good enough study to tell us at what level protection is good. So if you did a test and it said you have 1,000 units of antibody response, and I did the test and I have 8,000 protective, do you need 8 to be protected? Do you need 4? Do you need 2? Do you need 1? Are you okay? We don't actually know. So if you had 0, you'd know that was very disheartening and that's not going to be protection. But if you had A level and it was less than, say, average, you still don't know if that's protective or not, which is why the commercial test for antibody levels is not available. And for people who travel to the US, many of you might have done it because it's done quite routinely by private labs in the US, but they don't really have the confidence of how they report out their results to tell you what use that number is to you.
Okay, Betty?
Okay, I guess that's the end of the questions. Maybe Dr. Owen, you could close your share screen,
Good idea.
and we could see you for a moment. Thank you so much for taking your time. I know this is your personal time, and we really appreciate you taking your time to speak to us. It's very valuable. So this information is, all of us are going to take some time to process it and digest it. And if we have further questions, is it possible to email it to you?
Yeah, I'm completely fine with that.
Okay, so if any, I will make sure that everyone gets your email. I have your email. So thank you again, and
Yes, thank you.
we'll actually let you go because we have some announcements to make, and we don't want to take any more of your time. And so thank you again. I can't thank you enough for your time, and we hope that your clinical trial goes well. I'm sure some people on this call will be very interested in participating, myself included.
Yes, exactly. Yeah.
Okay.
Have a good day.
Again.
Bye.
Thank you,
Bye.
Dr. Owen.